And welcome to the New Brunswick Heart Center academic rounds. I was going to talk today on the MitraClip, and hopefully I can bring you back to what I was trying to do here. Share my screen. I'm assuming you can see that. Can someone just let me know if you can actually see the screen?
Yeah, we can see it.
Okay, beautiful. So today's topic is really to clip or not to clip, and really an approach to mitral insufficiency for everyone. It's really about increasing our ability to have multiple options for our patients. So a little bit of perspective. So I'll obviously explain a little bit what I mean by MitraClip and percutaneous mitral valve repair, a brief overview of the evidence, but not delving too deeply. I really didn't want to make this a review of the current trials. Where do we sit on current guidelines and current utilization in North America, which is a little bit eye-opening for many of us, and certainly opens the idea for a little bit of expansion potentially. I have a couple of case examples to sort of illustrate the points that I'm trying to make, and a little bit of thoughts on patient selection and what are we looking for. So the clinical problem is really the mitral insufficiency is a problem where obviously the mitral valve, which from a surgeon's point of view, this is the view that we see here. Let me see if I can make a little laser pointer. You'll see that a little bit better, looking en face, the anterior leaflet and the posterior leaflet in the back. And mitral insufficiency can generally be classified as primary or secondary or structural or non-structural. Primary means there's something wrong with the valve itself, the leaflets, the chordae, or any of those things, while secondary is really a problem with either a problem with the muscle of which the attachments around the valve that have dilated or changed or pulling on the valve itself, but the actual valve is actually normal. So this is an important distinction. Primary or structural problems tend to be, there's lots of techniques for us to repair these valves, and the results are really well explained and well predictable, while secondary MR is the most common reason we'd be thinking about is from an ischemic point of view, where you have a dilatation of your ventricle or ischemic changes that would lead to tethering or pulling of the valve. And therefore, repairing the valve may not actually change the dynamic of that patient or the outcome for that patient. So percutaneous repair for mitral valve is really not something new. In 2011 was really the first publication of the Everest 2 investigator trial. This was a small trial, but still was a pioneering trial where they compared essentially a percutaneous repair versus surgical repair for a combination of mitral insufficiency, but largely primary versus as compared to secondary, which is mostly what we see currently. And this is what they did. They essentially copied or tried to replicate what is done surgically as an Alfieri technique here, where if you have a central jet of MR, you can actually collapse the two leaflets together and make a two-orifice valve, and in that manner are able to reduce the amount of mitral insufficiency. And this is a steerable catheter that is placed through the venous system, through the septum, to achieve that. So a guidable system that comes from the groin, so entirely venous procedure, except for the arterial side by crossing the septum. It's relatively well tolerated by patient. It's not exceedingly invasive, and that was used for the treatment. And the 4-year results for that trial were published in 2013. And while in many ways, the surgeons, I've always said, the results ultimately of that trial was that surgery was better for largely structural valve problem than percutaneous repair in terms of recurrence of mitral valve insufficiency and outpoint of death and heart failure. There were still some very important things to learn from the trial. And remember, this is a small trial, so not really powered to answer many of these things. Is that there was a sense that in functional or secondary mitral insufficiency that perhaps percutaneous repair might be better, while for degenerative or structural or primary, that perhaps surgery was better. But also an age difference here where older patients may do better potentially with percutaneous intervention versus the younger patients who might do better with surgery. So these are some of the tidbits that were learned a little bit from the Everest 2 trial, which was a landmark trial to make the therapy actually used in clinical practice. And this is what the landscape essentially looks like overall. is in 2011, the Everest 2 trial results came out, the 4-year result in 2013. FDA approval was in 2014 and clinical application worldwide. And in 2018 was the beginning of the program at the Brunswick Heart Center. And if you remember, in the heart failure side of things, so the functional mitral insufficiency or secondary mitral insufficiency, the COAP trial and the MitraFR trial came in 2019. And these were important because one is they competed, they sort of provided the, I can't change my slides here. Whoops, see if I can do that. Is that you saw the survival, event-free survival being better in the percutaneous repaired patients versus the control patients over a 2-year period, particularly for the COAP trial. And this was an important distinction to the MitraFR, which did not show a difference between the two. And the COAP trial was particularly rigorous in terms of its optimization of medical therapy, the selection of patients that had more severe mitral insufficiency and less dilatation of the ventricle were some of the criteria that were felt to be important in that trial. And so we tend to follow guidelines in the setting of a heart failure that follow the COAP type idea of how we follow these patients. So this is the growth in percutaneous mitral valve intervention over the period of time, and TEER means percutaneous edge-to-edge repair, while TMVR is really the sort of small group of evolving percutaneous mitral prosthesis that are being used. And you can see that since 2014, there's a growing trend in the United States of certainly edge-to-edge repair. So the MitraClip group in 2020 is a partial year, obviously. And then every year, almost a doubling of the numbers, particularly after 2018, when the COAP and MitraFR trial came through. The next slide is really what I think is particularly interesting is if you look at the distribution of the type of patients you have here, is while most of you would think that most of the percutaneous repairs are done in patients with secondary mitral insufficiency, is the reality is most of them are done in patients with primary mitral insufficiency. So there is a group of patients. So you can see here that the large proportion in blue, for example, in 2019, this is primary mitral insufficiency. That means a structural valve problem, while only a small portion is in secondary, and then obviously a mix of primary and secondary in the others. So something important to keep in mind. And what's important to keep also in mind is that these results, these are excellent outcomes for patients that are not considered surgical candidates. And this is where currently the guidelines sit, is when they came out after the FDA trial approval of this therapy was felt and indicated in patients who were believed to be a higher mortality risk with surgery, and therefore, and what's important, they were able to describe that you can see the percutaneous interventions, the mortality in a hospital is around 2%, 30-day mortality around 4%, the 7.6 is just lost to follow-up. So this is of all these registry. And you look at 1-year mortality, it's around 16 to 20%, which in many of these patients are elderly and some obviously functional MR. These are standard, pretty much the type of result you'd expect, but you can see that in a hospital mortality and 30-day mortality is quite low in that group. So low procedural and hospital mortality is driving obviously the use of this technology. So the current guidelines for transcatheter mitral valve both fit in the primary on the left side. It's a complicated little bit algorithm, but just to focus on is when you assess patients for primary structural valve problem in whom you feel the surgical risk is higher or high, but the life expectancy is reasonable, this is a class 2A indication for these patients to be considered for MitraClip. And this is something that we don't always think about in these types of patients because the technology now allows us for us to think in that way and allow us to do it. And prohibitive surgical risk is sort of a gray zone in terms of what we considered. So high risk, for example, if you remember the TAVI trial, was in the 8 to 10% mortality risk, and that's a predicted mortality. So that's potentially a little bit more number of patients. We obviously, if you look at the data from what is published currently, some are obviously related to surgical risk, but often these are elderly patients with frailty involved and other aspects that may be considered also as increasing their surgical risk. On the secondary mitral insufficiency side of things, obviously, again, the same idea is, except that in this case, there's really a strong emphasis for in patients who have mitral insufficiency in a setting of depressed ejection fraction, in which there's a really optimization of medical therapy is key prior to consideration for transcatheter edge-to-edge repair. And this is where it's important when we assess these patients, if it's felt that we're not on really the maximal medical therapy, is the current guidelines would recommend for us to have 3 months of stable on optimal medical therapy before considering edge-to-edge repair. So I would show these. This is the first example I was going to show to you guys because it illustrates, whoops, sorry, I didn't mean to do that. Hopefully I can come back. Hopefully my other clip is going to start too to illustrate, but essentially you can see here, this is a patient with very depressed ejection fraction. You can tell that both right and left ventricle are not moving well, and clearly these valves are not meeting in the middle. And you can see the mitral insufficiency jet on this side. So this is classic of a secondary mitral insufficiency from tethering. So as the ventricle dilates and as the pressure increases here, there is pulling of the leaflets, and actually the leaflets do not meet in the middle. There's actually a coaptation gap here. And if you were to draw a line across here, the annulus, there's a depth of coaptation that is quite low. This is a classic of tethered leaflet with severe mitral insufficiency. So this kind of patients, if we were to assess, and we did assess this particular patient, what's important is this was a first presentation with heart failure. So investigation is key here in understanding the mechanisms, trying to rule out obviously other causes for the ventricular dysfunction. There was no coronary disease in this case. This was really a dilated cardiomyopathy. So goal-directed optimal medical management is really important. And then the focus would be to really try to reevaluate and see how they respond to medical treatment before considering intervention in that particular case. And this would be the classic type of patient we would consider for MitraClip. But if that coaptation gap is actually a little bit too big, or that depth of coaptation is too low, these are cases that would be actually quite challenging to do from a MitraClip point of view, and may actually difficult to do, because the result would not be. And for the same reason, in this setting, a particular patient like that, where EF may be actually below 20%, is that from a surgical point of view, the risk of surgery is very high and actually fits outside of clinical indication for surgery because of that. So you may be looking at other therapies. Obviously, you'd be looking for optimization of heart failure, CRT, left ventricular support. Whoops, somebody here is... I'm just going to mute someone there. There we go. Should be good. And reevaluate this patient. So the next case that I want to show you is a little bit different. This is you can see a completely different scenario where you have a structural valve problem. You can see here the leaflets is actually prolapsing above the other one. The leaflets are moving well. They're moving all the way to the annular plane, and there's clear rupture of the cord. And this was a particular patient with previous heart surgery, some pulmonary hypertension, elderly, and quite deconditioned in many ways, that we assess for MitraClip. And this is the jet of mitral insufficiency. So while this would normally be, from a surgical point of view, the type of patient we would want to repair, the surgical risk here was felt to be high enough to consider for MitraClip. And this is what we did. Again, I wanted to show one more echo. This is a view of the 3D echo. And for those of you who do 3D echo in this type of patient, this is particularly helpful to us, particularly when we consider for MitraClip. This is a surgeon's view where the anterior leaflet is upper and the posterior leaflet is under. And you can see the segment of P2 here, or the second segment of the posterior leaflet that is prolapsing towards me or towards the surgeon to really illustrate where the defect is. On the next slide here, you can see that a clip was placed here in the A2, P2. This is that same patient. And you can see here the residual mitral insufficiency that is much better than what was present. And this was a clip patient for us in the past year or so. That was for structural valve problems. So you can see that primary mitral insufficiency can be addressed by clip. and as well as secondary. So both of them have indication for that. So what's the experience at the New Brunswick Heart Center? So we're an early program. We've only done 20 cases or so far. We have potentially 2 planned for this month or this coming month. This is an early program. The majority have been secondary mitral insufficiency, which is contrary to what is currently published. That's more than 80%. At 3 actually out of the 20 were structural valve problem. There's been obviously some unforeseen events that have affected the program in many ways, the pandemic and unfortunately the passing of Sorab, who was really the key member and person that was driving this program. But Brent and Bob are still working on the program, and myself, to obviously make this feasible, and obviously we want to pursue this. So what is key here to patient selection? Well, patient selection obviously is important, and assessing that patient on a global basis is really important. So good echo is critical to grading obviously the severity of the mitral insufficiency and trying to understand the mechanism for that. So transesophageal echo is important, as well as a few things that we look for that are absolutely critical when we do transesophageal echo. And there are a few published outlines out there of the kinds of things we look at on a TE. And some of the things we look at are bicommissural view, for example, where we can see all 3 leaflets, the posterior at each commissure and the anterior leaflet in the middle, where we can see the breadth of the mitral insufficiency jet. Is it only in the middle? Is it on the side? Is there more than one jet? Because that certainly would affect how we would repair the valve. The size of the left atrium is also very important, and the septum height, because we need to go through that septum and be high enough to be able to maneuver in that left atrium to be able to get in, is also something key. And lastly is the mitral valve area that we need measured. We need 4 centimeters squared of mitral valve area to know that if we clip, we're not going to end up with mitral stenosis. So the assessment is really important. And obviously to meet that patient, to really get a good assessment of obviously, are they a surgical candidate first? And if they're a surgical candidate that is reasonable, then surgery is often the primary way to go. And if they're not, what is their functional status? What is their surgical risk? What is their percutaneous risk? Are things that we assess. So this is what I mean by the types of echo images. So on a 3D image here, looking en face at the valve, you know, the jet of mitral insufficiency and the size of the gap is important. There's a particular measurement that we look at. We obviously need a posterior leaflet that's a certain length. We actually measure that leaflet. If it's less than 8 millimeter in length from the annulus to the tip of the posterior leaflet, it's too small for us to grasp and be able to hold it. Here's a coaptation depth. If you draw a line through that annulus, that depth here, if it's more than 11 millimeter, it is very hard for us to be able to know whether we'd be able to bring those leaflets together. The flail gap that I showed you in one of the patients before is if there is a gap between the 2 leaflets that are not coapting together, is really important, again, to not be too big. So there are obviously some very specific criteria, but these indications are growing over time. We used to start with a clip. In the past, the first clips, we would open the clip and clip both leaflets together. Now they actually have the ability to grasp and clip and grasp each leaflet separately, as the calipers on these things have been designed now to allow that to have better release and better capture. There are many patients we assess over time that are not possible to be done. So there are valve problems such as rheumatic disease, and this is why I put this here, is rheumatic valve disease, extensive calcifications, or other extensive disease of Barlow's that are quite complex with very thick leaflet that are very abnormal. These are not possible to be done. So obviously looking at the echo is very important for that. And finally, there are obviously all sorts of anatomical things that we look at to see and to judge whether these patients are doable or not. So again, assessment is complicated, but important, and does require often reassessment. The team here is a picture of our team, the initial team for the first MitraClip, and obviously that team has grown and expanded over time, but it continues to be a multidisciplinary team that includes my colleagues from anesthesia. You see Jennifer Cloutier here, my colleagues obviously from interventional cardiology that are driving this program. There's us from cardiac surgery to obviously assess the surgical ability for us to deal with this surgically, the surgical risk, and obviously all the nursing team and the support from the company on this. So in summary, I think treatment of mitral insufficiency not includes an increasing number of options that are available to patients, and really trying to judge whether surgery versus percutaneous repair should be considered. MitraClip is limited to patients of high surgical risk, but this is nuanced. The STS definition for high surgical risk based on that is in the range of 8 to 10% mortality risk based on an STS score. Often there are other considerations such as age, frailty, or other aspects that one might consider and consider these patients. And the evidence is really supportive from a secondary MR point of view in stable patients on optimal medical therapy with heart failure. These patients likely benefit based on co-op trial. And in primary mitral insufficiency patients, these are patients that are judged to be of prohibitive risk based on the Everest trial and the registry data from that after. So I think the Heart Center, we're striving for excellence in mitral valve interventions. I think our peer review and heart team approach to mitral valve intervention is something we currently do and really want to foster. Mitral valve surgery, including minimally invasive surgery, is something we offer, and we obviously offer percutaneous MitraClip program that is we hope can grow over time slowly and provide obviously the care for our patients in the province. The future for us does include recruitment of a surgeon and specialized in training in mitral valve intervention who's currently in England doing that fellowship and will be starting in the summer. And obviously percutaneous mitral valve replacement options that are going to come down the line. And we want to have the structure in place that will be able to offer these options. And obviously I need my interventional colleagues and Brent, who's our structural valve expert, to really champion these ideas. We certainly did our first mitral valve in valve not that long ago, and this was a big success for us and really important. And so we are able to do these techniques and hopefully bring that in the future. So with that, I am going to close and thank everybody for joining. So I'm going to stop sharing so that I can open for questions. There we go. Anyways, thank you, everybody. So I don't know if there was any question on the chat. There is no questions on the chat.
Jeff, sometimes we get these consults for someone with severe functional MR, that EF 30% new diagnosis that is not yet on goal-directed medical therapy. But do you want to know about these people then so you can follow them and schedule a reevaluation once they've been on medical therapy? Or do you prefer to wait to hear about them from their primary cardiologist once they've been on medical therapy and be re-referred?
I don't know what the best approach is, to be honest, other than to say that it is helpful to see them early so we have some idea, because you might find out right away that it's technically not feasible. And so you won't be thinking all the time, oh, there was always going to be that option in the background. So there are many patients we follow currently that we've reevaluated multiple times. And then over time, they fit criteria either from a medical therapy point of view or from a severity that progresses over time. So I think there's value there. I'd encourage a little more from myself to communicate better with my cardiology colleagues in the province to try to help them in terms of managing these patients and what we're looking for. The goal-directed medical therapy is really one of those that's, it is very beneficial for those patients. The ones obviously that you select in the end that benefit from the medical therapy are the ones that end up benefiting the most also from the intervention, which is interesting. So there are obviously a subset of patients there that no matter what you do are struggling and you may not be able to help them. So this, I'm sure, very vexing and challenging for everybody.
Do you think we should have all these people, and maybe they are already followed directly in a heart function clinic? And, we can't follow everybody here, obviously, but I think that would probably be something that we would strive to as a province.
Yeah, I mean, if I were to look now, we assess, on average, just a few patients a month, particularly for that exact question. So it is not a large number of patients currently. So we are currently following them all within the MitraClip with Heather, who helps me. She's our coordinator also from the TAVI side of things. But you're quite right, is these types of patients would be ideally the type of patient that would be in a heart function clinic, wherever they would be, whether they're Moncton and Fredericton or St. John or other places such as Bathurst that would have that kind of access. I think you're quite right. Any questions from you guys? I see Ron is on the call and
Sure, it's Ron. I'll just ask. So when we're seeing patients with similar indications, mitral insufficiency, whether it's primary or secondary, would you prefer that we send those referrals to you, Jean-Francois, directly, or are we sending it to a team, or do we call whoever's on call, or what's the process you want us to follow now going forward?
Yeah, it doesn't matter either way. I think all of them will eventually trickle out to us, but the part of the reason for me to give those rounds is, as you know, is while we do have a team in a way to refer directly to either Brent or I or Bob through the MitraClip, and then Heather helps us organize all the requirements. You know, sometimes even within our system, people don't really know that what's going on exactly and how far we are ahead in this program. So anyone that you believe that in my mind, that has mitral insufficiency of which surgical risk is higher, theoretically should be someone that you would consider for this as a therapy. So it's really for all of us to be a little bit heightened in terms of our assessment and potential. There are patients that would be very good candidates that potentially would benefit here. So as long as something is mentioned in the referral or the question being asked as potential MitraClip, then it does signal right away that a few individuals would see them with that in mind. And I'd be happy to see them anytime. So if they come through to me to the office here, I would certainly arrange that.
Thanks.
Okay, so thank you, everybody. This was a great opportunity for me to present, and I wish you all a good day. And thank you again for attending.